who will be talking about CST Cerner benefits evaluation and their work around the value look. Today we have Michael Lee, Senior Director of Advanced Analytics at Vancouver Coastal Health, who also happens to be a HINF alumni, as well as Barb Cross, who is the Director of Clinical Informatics and Vancouver Coastal Health. And she's also the head of the Canadian Nursing Informatics Association, which is really fabulous too. So on that note, I'm going to pass over the presentation to Barb and to Michael.
Thank you, Elizabeth. I should know Barb also is a HINF alumni.
Yes. Well, I'm a quasi-HINF alumni. It depends how you classify direct study. Well, I was taking my master's in nursing, so I'm all in.
There you go. Thank you, everyone, for joining. It's amazing to have the opportunity to present to you today this very groundbreaking work that we have started trickling out since November. In respect of all of the approval processes that are needed when something this groundbreaking really is completed. So first, want to make sure that we take the time to acknowledge the ancestral and traditional unceded territories we're on. This is what the VPP is on, Vancouver Providence and PHSA. We didn't adjust these slides from the steering. But as a fourth generation Islander, I would be remiss if I didn't acknowledge the Songhees and Esquimalt, which is where we're coming from today. And I would encourage anyone, if you so choose, to put in the chat where you're coming from as well. I'll skip through that. This is a really important slide. I'm a big believer that products and services are made by people, not by organizations. And what we have here is a really tremendous set of people, both in terms of the team and the steering committee. And I know, having been involved from the get-go on this, that the steering committee made sure that the right people were available before the work was kicked off. The history of this is that there's been many kicks at the can around benefits realization in healthcare over the years. And although as you'll see, what we're bringing to you today isn't necessarily the be all to end all, because we've got a lot of work to do collectively as a community, we were able to progress how we do this work forward in a tangible and precise way to really show and light the path forward. So much more to come on the journey. I wanted to acknowledge in particular everyone on the left-hand side there, Megan Stowe, and we're here today for you, so Barb and Michael, Veronique, Nikki, Doug, and Hannah in particular on the core team. And then you see the steering committee is made up of very senior leaders as well. I won't go through all of those, but just to say that also Ryan Gerard in particular was effusively collaborative on the Oracle side to give us the resources that we needed to do this work. And it would just absolutely have not been possible without that, because the technical complexity that underlies the efficacy of this is so complicated. And another important facet, it really was done across Vancouver, Providence, and PHSA. And I've had several people actually reach out that the implementation, as you'll see on the roadmap here, so I'll skip forward here, around some of the successes to date really is underlined by all the hard work that we've done in the province to collaborate to create the build across Vancouver, Providence, and PHSA, in particular between children's and women's and VGH, for instance. If there are complicated births or other things, that would not have been able to happen as smoothly before. And as I mentioned, several have reached out to me even in the course of setting up this presentation about how impactful that's been on their family. So just to step back 1 second before we get there, the approach and scope really was very deliberate. These are the 3 questions on the right-hand side. It's very easy to get lost in the purpose of a benefits exercise. They tend to be larger than, say, a PDSA or a measure, evaluate, learn type product development cycle. they tend to be strategic, and they tend to be everything. So the fact that we're able to have a locus around these three questions, what are we realizing today? What should we be realizing? And how do we know that these benefits are actually allowing us to achieve better healthcare and other strategic outcomes? You'll see from Barb later that these were very specifically mapped to outcome statements. And there's a methodology here beyond the technical measurement efforts that really made this work successful and integrated into these three questions. This is sort of the high level summary of what was realized. And I don't think there's a lot of surprises here, perhaps. I won't get into all the detail because we have a lot of other slides around that. But suffice it to say that a lot of the inherent benefits of an electronic health record so far have been realized, at least partially. So digitally enabled processes, even things like centralized registration systems. So that comes under a successful activation of a single enterprise solution, and operational efficiencies. So even things like EMPI and background records quality work, some of the pharmacy supply chain and inventory, et cetera. The emerging piece really, without going through all of each individual bubble, is around the clinical change. And you'll see a theme here in terms of what the current looks like around some of what I mentioned versus what the future looks like in our journey towards clinical transformation, where the biggest opportunities are, and the biggest opportunity for all of us as health informaticians to make an impact is really where the clinical rubber hits the road. And so in our assessment right now, that's really the big piece that requires effort, resources, and energy.
I just want to add that you'll notice on that slide, if you could go back, Michael, one, that road never ends. And I think the bubble that.
And it gets steeper too.
And it gets steeper, that denotes destination, there isn't, it really isn't. It's continuous system transformation. And that is actually what our North Stars should be leaning towards. And they should be continuously evolving.
Thanks, Barb. So again, we have slides on each of these. This is sort of a preview of the summary of what we found for each benefit stream. Well, what is a benefit stream? That is explained in some later slides as well. So just going to flash this up quickly so everyone can see sort of the breadth of what we were looking at. There are 4 benefit streams, as you'll see from Barb, and there's quite a lot of detail that we went into that we'll show a little bit of a preview of, but we can't go into every single area, bearing in mind that this was a 6-month project. I will note there, though, with a 6-month project, the amount of work that we did as a team was a lot of work. 6 months, as we know, is not a lot of time as it comes to the different epochs of the healthcare system. So we're able to really come together as a team and effectively do this work, bite off something that is tangible to show results and to set the path, as I mentioned before.
Do you want to talk about that red note? That was a critical.
Yeah, why don't you go ahead?
Oh, just that with this project, we weren't suggesting by any means along the way or even at the end that this really was the end, that we were going to identify and define the benefits, and we were going to talk about the outcomes that we achieved and those kinds of things. And that was that. We came from this sort of, empty space worldview, if you will, where we didn't have any expectations other than, could we just get this moving forward in some way, shape, or form? And the comment that you'll read in the corner there, the top right corner, is that really the ultimate reality check at the end of it was about not realizing all the benefits, but that paying attention to where we were in that moment was about really converting 3 health organizations throughout a project schedule and timeline. That it really wasn't, we weren't expecting to have all of these outcomes realized or benefits realized that when you get on a roadmap and you follow that schedule along, you're simply converting, and that's the mindset of the health organizations. You hope you're accomplishing things and improving health systems along the way, but really ultimately the main focus has been on conversion and just getting these sites live and getting them starting to use all those digitized care processes. So I just want to call that out.
Yeah, for sure.
Sorry.
No, that's great.
I'm gonna intrude. Sorry.
That's why we complement each other well when we work together. So in terms of recommendations, again, these are things that we've all seen before, whether through accreditation or whether through different reviews that have been done. We've brought it together here based on our experience. Data is huge, and we'll talk about that in a minute, because actually we're kind of drowning in data now. So we went from a state maybe 10, 15 years ago where we didn't have enough data to now where we have too much. And it's so easy to go down a rabbit hole and constantly analyze things. So you'll see here how we matched the literature to the data to minimize the data measurement, actually, because it's just not practical in 6 months. And then there's the ongoing requirements of education, change management support, and integration into a learning health system, which is really what you see on the right. So that covers off quintuple aim and quality and other things. So this is over to you, Barb, around the project background.
Yeah, so I don't know how many of you virtually and in the room here are aware of the Clinical Systems Transformation Project, but it really started, quite some time ago, like 2014, I think, was the initial sort of kickoff year. And it just, evolved over time with people and really project focus and intent. And we finally kicked it off officially in 2018 when we actually brought Lionsgate Hospital and Squamish Hospital live as the first sort of demonstration sites of the CST project. And I think its ultimate intent was to bring a primary EHR platform. I like to think of it as the spine of something, meaning that it brought multiple clinical information system type modules together on a single integrated platform. And we leveraged that platform. Back then it was Cerner. Now it's in its Oracle iteration. So that we could all share one person, one record for better health, and bring together all of our providers and care team members and patients and families together across these three highly integrated health systems. Because when you think about how a person, a human, moves across health systems, especially in the Lower Mainland, from birth to death, all of that data, all of the storytelling within a record is housed in silos. This project gave us an opportunity to really consider it in a single instance across the platform. So you can see all of the information bits in the widgets there, with 40,000 users across 3 health systems, 46 healthcare sites and 300 clinics. There's even more as we've continued on, especially in the ambulatory space, which is substantive across these 3 health systems. Providence Health System is now fully live on Oracle EHR and using and adopting and getting more information along the way as they go. So that was a big accomplishment, a big milestone. Vancouver Coastal Health is well underway and almost complete, with Richmond coming live in June, which is really exciting, and they need to. And then continuing on with its ambulatory clinic spaces coming live as well. And then Powell River will likely be its last sort of bigger, small community hospital site. And then Bella Bella and Bella Coola are live from a clinical viewer perspective, and some registration, I believe. So the reach is incredible. And then PHSA, providing provincial health services, is really well underway and almost finished its clinic conversions as well. So it's quite exciting. And you can see the lab resulting that's occurring within Cerner or within Oracle's EHR, as well as the external labs coming in, which has been integrated along the way. And Island Health is doing something very similar as well within its instance of Cerner. So 4.1 million patient records and growing, because every time a patient family intersect with either of these three health systems, their digital record is created at the time of registration. And their old records are scanned. So if any paper copy versions are scanned, and so that they will remain in a PDF format. So that will continue. The methodology, oh my goodness, this is so where I get excited, because it's like the launch pad. Like, how do we move forward with something so complex in terms of how we're going to answer those three questions? And by the way, Project Board actually only asked us one question. We added 2 other questions, because we said, we're not going to do this if we're not going to answer well, what aren't we realizing and what could we be? So we added those ones for context. But in terms of the methodology, when you think about benefits, there's benefits evaluation, meaning you're simply evaluating those outcomes and whether you achieve them or not. What we wanted to do is kick it up a notch and look at realization. And so we're looking at all sides of the coin, if you will. And then how do we really think about understanding how do we get to evaluate outcomes? And what happens typically in health organizations today around the world, by the way, not just within Canada or within BC, it's what our executive leaders and really our sort of mid-level management deal with on the daily is KPI outputs. So what happens when you measure KPIs? You get an output, you get a data point, you get some measurement, and then you sit as a collective and think, so what does that mean? What's the impact? What is it how are we using that information to inform the outcomes we're actually trying to achieve? That's really the state that we get to, where we get stuck. And I think personally, in my experience, it's been an ongoing gaping hole, if you will, in our dialogue. So yes, the KPI measures are super important. They're what we need to help inform whether we're achieving those outcomes and then ultimately achieving the benefits. And so that was really the crux of how we got to this methodology, this approach. I haven't been able to find in the literature some sort of mirror image of this approach. And I'm sorry, I made it up in my brain. And it's always open for redesign or whatever is needed. But essentially what we're looking at is benefit streams to provide contextual framing. So it's almost like putting an ontological perspective on what is it that we're trying to understand. So for us, what we wanted to lean into was clinician end user experience, the quality and safety aspects of care and services in our health systems, the patient experience and their outcomes. That's a biggie. And we've only just scratched the surface. And then health system transformation. The project team was trying to provide some sort of a platform, an integrated platform that could be used by all of our care and service teams and providers. But if we don't understand what it is that we're actually trying to achieve within health system transformation, then what are we doing with this project? We're just putting stuff in and then we walk away, which we know we don't do. So within each of these benefit streams, we identified, we worked with our steering committee members and we asked them, give us your top 10 KPI priorities. What is super important for you as an organization to measure and understand? So they did. They gave us those priorities. We applied some rigor in terms of the analysis and how we landed on those KPIs that we were going to measure. I will say, Michael would add to this too, I'm sure, that those KPI measures were super critical because we had to be able to measure them, which meant that we had to be able to get data and then be able to ultimately measure the KPIs. So we we had to choose KPIs in some instances just purely based on whether we could get access to the data, either through Oracle, through Cerner's Lights On back-end platform, or through surrogate data in the literature, which we used a lot of. So you'll see those, just the KPI focus within each of the benefit stream. And then, so the KPIs gave us a measure, and we had to think about what is the actual desired outcome. So you'll see this further along in the slides.
So let's just move there.
Yeah.
Actually, this is the frame, and I'll just add to what you said, Barb, in that important kind of teachable moment in a way that we got this list of KPIs. It was sort of soup to nuts.
Oh, you could show them that. It's at the end of the deck.
It is,
Yeah.
if we have time.
Yeah.
But essentially, we had to modify them, working with our steering committee, because what a lot hasn't been talked about in analytics, that a metric is a metric, but it lives in a context. So measuring it for benefits realization is very different than say you're doing a pharmacy supply chain improvement project. You may actually measure the number of medications dispensed, but it's a very different metric than when you do it for benefits realization at a system level.
Yeah.
The definitions, the denominators, everything. And it's something that's often overlooked and never talked about, because people will just ask for a specific metric. So a good takeaway from today is know the level of what you're measuring. Average length of stay is another one. It's like 10 ways past Sunday, but that's very different from a patient flow management standpoint, patient by patient, as opposed to looking at evaluating or doing benefits realization on, did you reduce length of stay due to better medication practice? Very different measurement exercises. And so we were really good, I think, at teasing that out and really starting to understand that. And then essentially deconstructing a logic model kind of approach, whatever you want to call it, around how that streams into each
Many debates
benefit
about that.
stream, so that we weren't just randomly measuring things. So what we have next, and I'll pass it back over to Barb, is really starting to break down each of the 4 streams that you saw with the logic and the way that we measured them.
Yeah, I just want to add, when we were talking about this logic model, oftentimes we forget about what's driving us, what's driving our curiosity, what's driving the need to change. So we won't show you the crude depiction of the methodology, but it really started with the benefit stream, and then the drivers for that benefit stream, the desired outcome, which meant that was our North Star that we were trying to achieve so that we could realize our benefit. We really broke it down. And then, of course, all of our measures, our different types of measures relative to the KPIs. So you'll see in this, the framing, the way that we're presenting, in this instance, under clinician and user experience or clinician, we focused on clinician usability of the system. So the why is essentially your driver. So we want streamlined workflows, and we want to reduce staff burnout relative to the EHR use, because that promotes adoption of these new digitized care processes. So that's really what's driving this. And then the how is really the KPIs. So in this instance, we looked at physician nurse adjusted time in the EHR per patient seen, because we wanted to understand, are our people spending more time in this EHR? Because there's so much to look at. But when we compare ourselves to other health systems, other Oracle health systems, we want to know that we're actually in line with a pretty common standard, if you will. And we reveal that on the right side. And other KPIs like infrastructure and adoption, we looked at percentage of interrupted sessions, meaning downtimes, or particularly in the provider ordering CPOE entry process. And then qualitative analysis is really important because you want to balance not just what the hard data is giving you, but what are people actually feeling and experiencing in this relationship with usability. And then, as I mentioned, you have to be able to define your desired outcome. We actually separated outcomes out midway. We had desired outcomes, meaning our North Stars, in this instance around clinician usability of the system. Our desired outcome is really streamlined, efficient documentation processes that align with Cerner benchmarks with minimal to no system and workflow interruption. I could talk about workflow interruption to the cows come home because, oh my goodness, it's not just about your network infrastructure. It's about your devices and how well they integrate in those workflows. It's about the knowledge of the end user and do they know and understand how to efficiently use the EHR tools, those kinds of things. So there was the desired outcome, and then there is the actual that you see on the top right. The actual outcome that was realized or ultimately through evaluation told us where we were. We've got a little meter gauge there, but you can see EHR infrastructure consistently is performing well, meaning our uptime is really good. We are above standard in that regard. So that's a good starting place. Our end user documentation time shows minimal deviation from Cerner average, so that was good. Service desk results show opportunity to improve first call resolution and minimize end user disruption. So when I said I could talk about end user disruption, in that instance, it had a lot to do with the knowledge of the end user. If they don't know how to use and interact with the HR tools in an efficient way, it literally paralyzes them in their workflow. And that is not okay. That should not be okay. Our health system leaders should know and understand that. So that's something clearly I'm passionate about. And so our support people, whether it's through our vendor, which in this instance was NTT Data, providing a clinical service desk, first call resolution is important so that the end user gets back to doing what they should be doing. But it's also on the health system to really kind of mitigate the need for the end user to call the support person in the first place. So I always go back to that. So you can see how our KPIs unfolded through KPIs measured and those percentage points. And then you can see really ultimately where we landed in terms of realizing this benefit. We did through our calculations, thank God for Michael, who really helped us with those calculations that we could really understand our ROI because dollars matter in healthcare. And then we looked at more opportunities that would help us realize benefits. So that's really how we walk through the presentation of our benefits realization process.
And I would just add, Barb, that all of this was mapped through the literature. So Andre and Elizabeth, I'm sure you'll appreciate the response times based on the literature, the 2 seconds. And so that really, this looks very straightforward after all the synthesis to the slide. It was not. It was very difficult to know, are we looking at 2 seconds? Are we looking at 4 seconds? There are probably for every metric on there, there's 100 other metrics. How do you synthesize it all to what the literature is showing without reproducing the research? And then having the North Star Barb talked about, we spent a lot of time trying to understand the actual outcome we are trying to achieve with each of these. It sounds like it should be easy, but there are many different outcomes that can be chased. At the end of the day, getting it to this level of conciseness took a lot of time and a lot of energy. But Barb, to your point around the 4 coming straight from your brain, I have started using it for other things as well, because it is pretty well mapped to the quintuple aim and other frameworks and seems to work from a technology standpoint.
We really threaded the quintuple aim intent throughout the benefit streams that we identified.
Is the transformation part of the quintuple? We had a new.
Yes.
Okay.
Yeah.
And on that
We'll
note, I'm
see.
going to move to med safety because it's something that's really important in healthcare, going all the way back to Ross Baker's adverse event study in probably the early 2000s. And we're still not there in terms of our efficacy against this. So this has a lot of literature on it. And this is why I'm using this as an example of what I just spoke about with the importance of literature. Our calculations actually didn't use that much data from health authority sources. There's a lot of research on this. So we looked at our total admissions. We looked at our total admissions at Cerner sites. We looked at the prevalence or incidence, I can't remember which, of adverse events, preventable adverse drug events at each admission. And then we applied that number. We then looked at the literature, and it's less than I thought it would be, but there's still some literature on how EHR systems reduce preventable adverse drug events, and applied that number. So you sort of see the laddering effect here. But for those of you on the call that have worked in healthcare or work in the healthcare system, this is really the critical piece we need out of leadership. We need, as thought leaders in the system, to be able to understand this and not over-measure things. So at the end of the day, we ended up pulling a little bit of PSLS data, some other things, but not overfitting it, not over-reading into it, because there's different quality, data quality considerations with each data source. And then looking at, well, okay, at the end of the day, our discharge med-rec might be quite high, but our in-hospital barcode med-admin is lowish. It's 40 to 50%. So when you look at med safety, that's the weakest link in the chain. To be conservative, that's the multiplier we applied at the end to the savings, and went from there. So again, this is a good example of our methodology, because there's a lot of evidence here already. Why reinvent the wheel? We actually didn't need to go and do some fancy patient by patient measurement of discharge or admission med reconciliation. We used a lot of proxy measure stitching literature together before we then looked at our own data. We also worked with other researchers like Corinne Hall, who has done more on the adverse drug events as opposed to the overall medication safety piece. And she had a population analysis, which was roughly in line. So we're doing a little bit of reliability checking there. So like, none of this is groundbreaking. I'm not talking about neural networks or random forests or AI or all the sexy stuff, but it requires integrated knowledge and really hard discussions at the project team level. And I'd say, Barb, probably for some on the project team, it really stressed the thinking or the integrated thinking required in order to build this up. Like, there were a lot of hard days and hard meetings really challenging the thought process. And like, do we really need to do that? Because that'll take another 6 months to measure on the medication side. So yes, it's not the be all the end all, but it sets the framework. And then as we build out more measurement, we can plug it into how we do things here.
Well, and how to prioritize against your strategic aims, right? That's really what we're trying to convey here.
This is especially relevant with things like news, and actually with a lot of initiatives now, whether it's hospital at home or the virtual emergency or command center, we're talking about how to detect early deterioration, whether that's news or other methodologies, that this is really an important area. And again, we kept it simple. We're really not using the tools on the clinical side, as I said, during the executive summary portion, that we could. And we heard a lot of feedback about news and over alerting and other things like this. But at the end of the day, whichever the tool we choose is, we have a lot of opportunity in realizing benefits as it comes to the clinical functionality of the system, as opposed to some of the more mechanical or inherent components that come with an EHR.
So patient engagement is, as we mentioned, part of the patient experience and outcomes benefit stream. We focused on patient engagement, not because they're interacting with the EHR directly per se, and certainly not yet, but what we wanted to really understand kind of is just the beginning. So we focused on percentage of code status documentation, because that's a very intentional conversation for patients and families. We focused on completion of goals of care, especially for those nearing the end of life. There's lots of ROI around that one. Holy smokes, that was an awakening, and a percentage completion of patient discharge handout. And that was also revealing. And oh my goodness, as Michael alluded to just now, in the previous slide, all of this, these outputs and the outcomes evaluation that we were able to accomplish in this short period of time should be revealing for our executive leadership to really understand strategically, where do you lean in as an organization? Like, now that we have converted these sites and services, where do we really start to lean in and try and transform, like truly transform these areas of concern? And I just think that, I mean, this is quite a significant benefit stream because it's about the people we're serving, right? And so again, in this instance, we've got some, partial benefit realized here just with respect to, I would say, the code status documentation, that we're pretty good with that, as you could see by the 90% KPI measurement. But we're only at 32% completion of goals of care, which has huge implications at end of life, in terms of where the patient is assigned from a service level perspective. That was significant, I thought, and also length of stay relative to that. And then the completion of discharge handout. Now, this one really gets me as a nurse, I have to tell you, because I think our vets give our families better handouts for ongoing care of their pet than we do in healthcare. That's my analogy, because of a personal experience, but we are crappy at it, to be quite frank. We're not giving the patient and family what they need to take home to know how to carry on, because they're not convalescing in acute care anymore. That's gone by the by as of 1980. So these people are going home and relying on their networks, their support networks in the community, and relying on a follow-up visit maybe from their primary care provider, or not. And then, oh my goodness, what medications did I receive, or what blood products did I receive while I was in this acute state? So I could go on, but I won't. But this is so crucial for us to lean into, so that our patients get an ongoing plan for their ongoing care that they are in charge of ultimately. And I think there's lots of opportunity here for us to lean in.
Yeah, and just to note on this one, because this is a passion area of mine, and we're doing some follow-up that I'll describe in a second. This was based on a CIHI report that was done on the cost of end-of-life care in BC, so BC specific, back in 2008. The high level of that was that $1.9 billion is spent per year in 2008 dollars. We all know the cost of inflation these days at the grocery store, so it definitely is more now in the last 2 years of life. So we use that, as well as costs per stay in ICU and normal inpatient days, to proxy out the future benefit at 135 million. It's a very large number. It's something that with leadership was a very provocative statement, but we all know this, and we know that there's a lot of emerging literature now on completion of goals of care as really the starting point of changing the care pathway for a patient to be less intervention focused and more focused on what a patient actually wants, housing situations, etc., and even medical assistance in dying, our PACE and other programs that allow for more patient choice. So yes, this is heavy cultural change, but it's important with these very, very emotionally loaded topics that it is done rigorously like this and measured based on literature and research. We had very little apart from those 3 metrics to measure on what we're doing. Most of it was stitched together from existing literature, which I think is under leveraged as it comes to action in the health system.
Big time.
Because the report, having gone through it line by line, page by page, was very well put together and very, very relevant. I think we'll skip through some of these pretty
Yeah.
quickly. We looked at things like unnecessary lab draws. Obviously, that is appropriateness of care. No one wants to be pricked more than necessary. Again, not only the literature, but referring back to other initiatives underway, like choosing wisely. So you see how this as a benefits approach is integrated into what exists already instead of creating a carve out.
And we actually sponsored a lab analysis type
Right.
project, if you will, where we had our lab leader, medical expert, lead the analysis work to better understand exactly how well are we doing in terms of unnecessary lab draws, but also looking at power plan usage. So power plans, for those of you that don't know or aren't familiar with Cerner's EHR, is really essentially your order page and all of the pre-printed orders, if you will, for those older brains, where it all included labs. Oftentimes as our ordering pages get created by a collective of medical and nursing and pharmacy experts, oftentimes there's redundancy. And we create that redundancy, and then these orders go in, and then the patient gets pricked multiple times for the same lab that they didn't need to. So there was power plan usage or ordering practices usage across the 3 health systems. And the main focus was in emerge and critical care.
Yeah, and continuity on that topic also was really important. So looking at handovers, again, this is in the ROPs for accreditation. So we had actually reviewed that documentation as well to make sure we're in line, not just with the quintuple aim, but actually the accreditation quality and safety standards. And this is one of those big ones. Again, not too many measurement points here, really. And it's more about how to stitch together this story. Something which I'd be remiss if I didn't mention is our often overlooked colleagues in health information management. They actually have realized a massive something, well, you see there 47% reduction in registration errors. We know despite all of the desired outcomes on the quality side, so much of healthcare efficiency and effectiveness is really born out of having an integrated registration system. And that leads to not asking the patient multiple times for demographic or service information. It leads to identification and the downstream of med safety, because if the wristband has the wrong registration, then it doesn't matter if you're scanning it or not, right? So something that's not talked about a lot in terms of EHR efforts is the integration with the EMPI and really getting that registration and patient ID part so accurate that it no longer really is an issue. And that's really what we found here. This is probably its own presentation, so we're not really going to get into it, but to say that obviously from a cost standpoint, which you'll see later in totality, it's important to decommission old systems. It's something that we're really not good at doing in healthcare. Oftentimes things linger on. And so part of the project on the big R realization side was to actually actively create a project plan around archiving and decommissioning so that we have a path not only to deprecate old systems, but also to make sure that we're not hanging on to old training and education practices as it comes to leaving legacy systems hanging on in the actual health system. So probably another presentation, but we thought we would highlight that piece as well.
It also helps us determine what other opportunities do we have with our single instance of Oracle. And again, in the absence of an EHR strategy, which is also helpful for the organizations to make determinations about the types of solutions that they're going to procure in the future or add on to, or through interfaces or leverage through Oracle. It's just really important that we have that kind of mindset in terms of our decommissioning strategy.
Yeah, especially as another topic as well around integration of systems in the future, we're only going to have more of them. really adds the complexity of things like AI, et cetera. Certainly, our partners at Oracle are building a lot of capacity, but there's a lot of subspecialized functionality still. And standards around ONC in the States or InfoWay here around integration and FHIR and all these things. So like, we really have to deprecate the old stuff if we're going to be adding new functionality. Moving on to planetary health, a big ask from the project board and steering committee was really that we look at this. And a lot of these metrics would have gone into something more efficiency frame before. We managed to measure, for instance, proxies around the number of papers saved. We stratified out some of the lab test savings based on the test tubes avoided, et cetera, and really put this together.
Patient travel.
The patient travel and the fuel savings, as you'll see, the emission savings on the right there. I would say as well, Oracle Health in this regard was very helpful in not necessarily the current, but more so looking at the future, and was very grateful to be able to talk to their global lead for sustainability. And that was a fascinating conversation in terms of how our large vendors can help us get to where we want to go from this standpoint because of the economy of scale.
Well, and the environment, right? So cloud versus data centers.
Yeah.
And all of the implications from a planetary health perspective around data centers. So.
Which really
More to come on
requires
that.
that economy of scale.
Yeah.
We can't do that ourselves. This is an area, as you see, we have a lot of work to do around realizing benefit, and it comes down to system change, not just in terms of the technology itself. Where we have seen some gains, though, is around our Indigenous patient navigators and the ability to build consult orders and the dynamic ability, really, of the system to be able to implement new types of orders as we evolve to new types of programs. I know doing research on culturally safe ethnicity and disaggregated demographic capture, and that's a bit of a mouthful, that we're really not allowed to do that unless we have a solution or a product or a service for our clients. We can't just collect this information with no benefit. And so it's really important, and I wanted to highlight here with the cultural safety that our Cerner EHR now allows us to build that holistic program, not just to capture the demographic information we need to provide better care, but to then link it right to the better care program and the operations. So it's small right now, but that's really art of the possible first place that we've started. I'll hand it over to Barb. We did focus groups as well in the spirit of proper evaluation, and Barb will describe that interview process, and I can speak a little bit after that to the analytical process that we used.
Yeah, so I mean, again, it was a very short timeline and we managed to see 10 different groups. Some of those groups were an N of 1 or an N of 14 people. So we had opportunities to really engage our providers, nurses. As you can see, the breakdown of those that we interviewed, it was really, I thought, a good kind of representation, even though our N was small at 45 participants in total. Most of them were in person, so we got to experience the nonverbal as well, and then across multiple sites, across multiple care sectors as well, across the 3 health systems. So it wasn't just focusing in on one area. I would say that the biggest aha was in the BC cancer sector, because it really is a new space for Oracle in terms of development and EHR design. The big challenge for providers was around the collaboration or communication between the scheduling clerks and the providers, the order entry process, their care plans, their power plans, or ordering processes are very complex and complicated in terms of how the orders need to be followed at different increments along the patient journey. And so there has to be ongoing and a lot of attention focused in those primary areas, particularly in oncology or in any area where your ordering patterns are incremental or based on the patient scenario as the trajectory as it unfolds in front of you. You have to be able to kind of pivot in any given moment in the care process. So your ordering pattern has to be able to reflect that in the workflow. And that's not always easy to design because it's not static. And I think that is part of the challenge in healthcare. Nothing is static. It's very organic. We're always in a transitional state, and we're always supporting patients and families on their trajectory. So scheduling, ordering practices, and then accessing the data in that single instance. EHR was a huge benefit for all of our care team members. They talked about it at length and really celebrated the opportunity to be able to just log in regardless of where they're working. For many of them, they work not just at Vancouver Coastal, but they work at Providence or Vancouver Coastal and they work at PHSA. So wherever they have privileges or they practice, it just gave them opportunity to see that patient story, because ultimately that's what the EHR is really telling that patient story along their journey. So the focus groups was an incredible experience.
Yeah, and we
Very
received
passionate.
different information out of qualitative data.
Yeah,
So things like working cross-site, some of the complexities there, things like order sets are not necessarily always accessed in one area of the system, things that don't come up in quantitative data measurement.
yeah,
This is where, and again, on a whole nother topic, but talking about advanced analytics, this was where we chose to apply that. So we use natural language processing. And if anyone wants to nerd out about how to tokenize healthcare data
It was
and how
really
to
cool.
do sentiment
Yeah.
analysis, we can at some point.
We'll
We
talk later.
we had a really great
Expert.
computational linguist, Saffron Granby, who worked on it. I think she was going to try and join, but she really is the one, not me.
yeah.
But guiding that and moving it through the benefits work so that it's relevant and framed in the right context, I think was really important here because we only had 6 months. So we have a separate report entirely on natural language processing.
You can see the outputs of
Yeah.
her brilliant work. And she really leveraged not just the voice or the inflection of what the participant was saying, but it just came out. Oh, she was just brilliant. So the themes you can see depicted there just talked about all of the benefit streams, really: usability, efficiency, visibility, ongoing learning, some of the comments verbatim that came out as well.
And she also worked with Michelle, who is an anthropologist. So like, this is an emerging area in the health system. These themes came from NLP and were vetted using a process to look at the reliability of, say, Barb's nursing lens. So it's not just you hit a button and it spits it out.
Yeah.
And so like the team really did a great job in terms of the advanced approach here. The outcome statement piece, I'll hand it over to Barb. I know we only have a few more minutes, but this is really important. And I think the core, beyond all of the work that we did with, as I mentioned, NLP or any of the measurement side, just getting to this alone.
Yeah. These
It's a
are kind of
long
the
time.
concluding outcomes that we realized throughout the whole experience. But when you look at each of the individual benefit streams, there's a lot of words here. Apologies for that from a presentation standpoint.
Maybe
but you
just
can
choose
see,
one, I guess.
Yeah. There's high adoption as the CPOE rate is realized across VPP of 95%, which is extraordinary. And that just speaks to, again, the ongoing support the education, the design, how much not just the providers, because remember, in Oracle or in Cerner EHR, it really is about the care team entering orders. So providers, nurse practitioners, nurses, pharmacists, all members of the care team contribute from an ordering perspective. And so that was really, that was an excellent KPI to measure and outcome to realize.
And well researched in the literature.
Yes, yeah. And
the
then
target as well.
just the alerts acceptance rate, that although it's 8%, the majority of those alerts that were overridden were typically by the pharmacy community. And so there's still work to do, the EHR design work to do. And like, why are we overriding them? Like, get rid of those alerts then. So there's lots to lean in on that. Again, from a clinician impact perspective, we have high adoption on the allergy alerts or what was the other one? Oh, the HIV testing. that we've
Anything
already
with
had that.
HIE. Anything with
Redundancy.
HIE.
Yeah.
Where there's another system involved that you would never know if, say, the patient had an HIV test with their GP,
Yeah. And
the
then,
patient showed up and emerged, then you try and retest them and it alerts, right?
and then just the, not just the quality and safety aspects, but the ROI, what the ROI calculations were revealing. I think that was really an aha moment that we could lean into more.
So to cost then, for Barb's point, I won't linger on this slide, but suffice it to say that most of the annual cost savings, cost avoidance were described as things like the HIM and efficiency, and some that then fell into health system transformation inherent to the EHR. And then the outer edge on the projected is more on the clinical benefit side.
So that's a 10-year projection
Yeah.
that we used. Yeah.
And a lot of that is end of life, because 135 million or so is. Now, end of life isn't just one service or one thing, which is why it's so large. But this was how we chose to frame that overall. So I guess just in the last few minutes, the top lesson learned, really, there were some around what we described already. We won't go over that again, around how to build a benefits realization framework. But a big piece was around collaboration and some of the inherent learnings that we found coming in with sort of the highest level of approval within the three health authorities to get work done, and the collaboration that resulted, because we didn't come at it from an authoritarian standpoint. And so, for instance, in making this realization and not just evaluation, in 6 months, we successfully built data analytics dashboard tool for this across health authority. I've worked in analytics a long time. That usually takes a long time. And part of it was like, as something Andre and Elizabeth, we were talking about before this, I did the solutions architecture. So I have detailed knowledge of the different operating contexts, but also the different infrastructures, and the infrastructure was built to be built in 6 months, not conceptually something so difficult it would never be able to be delivered by the teams. So I think like that's just an example of how the teams really appreciate that kind of thought leadership from all of us as leaders in making a path that is achievable. And that's sort of, if anything, that's the theme for today. Like, I think rather than try and bite off everything, how do we make that path that's achievable? And that's really what we've brought you here today with the approach that we took for this benefits realization work. Any further thoughts, Barb?
No, it was just a crazy time. We
Yeah.
really leaned into this with great fervor and passion, I would say. A great initiative.
Great. All right. Do we have any questions?
I have a couple. But to answer